Okay, Dr. Jala, would you like to begin?
Sure. So welcome everyone, and thank you for joining us for today's webinar. I'm Niraj Jala. I'm the president of the Pennsylvania Association of Pathologists. And for today, we have a wonderful speaker on hematopathology for general pathologists, pearls and pitfalls. It will be presented by Dr. Erica Moore. Before we begin, there are some housekeeping things that we'll go through. Everyone's mics will be muted and will remain muted during the webinar series. If you have any questions during the presentation, please type them into the Q&A box located in the lower toolbar. At the end of the program, I'll bring them up and we will go to as many questions as we can in the Q&A session. So you should have something on the screen. If you need technical assistance, please type your need in the chat box and somebody will respond to the chat box when you have any questions that can be answered. In today's agenda, we will begin the presentation and it will end around 12:45 p.m. There will be about 10 to 15 minutes of question answer session and we will end at 1 p.m. The Pennsylvania Medical Society designates this as a Category 1 AMA credit, and physicians should only claim credit with the extent of their participation, which is what you have on your screen. And CME will be awarded at the conclusion of the entire webinar series. And how to get it, you will be able to see it. Portion of the webinar series is also eligible for the American Board of Pathology SAM credit, and we will be able to see that. With that, we'll introduce the speaker. Dr. Erica Moore has completed her med school and anatomic pathology and clinical pathology residency training at University of Pennsylvania, and she followed that with hematopathology fellowship and clinical instructorship at University of Pittsburgh. She is currently assistant professor of pathology in the hematopathology division at University of Pittsburgh, where she co-directs the hematology lab. With that, I hand it over to Dr. Moore.
Okay, I'm just going to get my slides up here. Okay, well, thank you, Dr. Jala. So as he mentioned, I'm going to be talking about hematopathology tips for general pathologists with sort of a focus on things that you might see in the community, you know, working up your own lymph nodes, and we'll do a little bit on peripheral smears at the end as well. So sort of divided into 4 sections. The first is with an emphasis on what we think about typically as heme stains and how they can lead you down the wrong path because they're not entirely specific. The next section will be about flow cytometry and how that can misdirect you. The third will be about hidden lymphomas, and the fourth, as I mentioned, peripheral smears with an emphasis on blasts. Okay, so first, heme stains like that we like to think about, you know, doing these stains and that they indicate it's a hematopoietic tumor, and in cases when they might actually not be hematopoietic tumors. So this was a case I had a few years ago. It was a 32-year-old man. He had a liver mass and he had had a liver transplant at some point in the past. And the tumor was really necrotic. It went to surgical pathology and they just did a bunch of stains and nothing stained except for LCA, or what we call in the heme world CD45, a leukocyte common antigen, right? And so that's like the typical stain and surge path when you're staining for a bunch of things and you see LCA positivity and you say, okay, we can send it to heme path. This is a heme tumor. So that's what happened. It was sent to us with suspicion for a post-transplant lymphoproliferative disorder because the patient had had a transplant in the past. And unfortunately, I had this case at a prior institution, so I couldn't pull the slides for you, but I'm still going to kind of go over the themes of the case, but without the specific slides from this. So this is a different case, a case I had a few weeks ago, a diffuse large B-cell lymphoma. And I just want to show this to you. This is obviously entirely necrotic. And you can see all the extensive coagulant necrosis in the ghost cells here. Just to illustrate that CD20 is a great stain when you're working up a potential lymphoma for a B-cell lymphoma, because it will stain in the necrotic tumors. And you know, on this stain, I did a PAX5, which is another B-cell marker, and that was dead negative. But then the same section, I did a CD20. You can see this beautiful nice diffuse staining, and it's really staining the individual ghost cells here. And so CD20 is great, you know, and that is reliable in necrosis. And CD45 can also stain necrotic hematopoietic cells. However, an important pitfall for you to know about is that CD45 or LCA can definitely stain necrotic non-hematopoietic tumor cells as well, which was the case in this liver tumor. And so this is a paper from a while back, actually from Penn, and you can see they had several cases here of carcinomas where they had LCA staining in the carcinoma, in the necrotic portions of it. And it wasn't just cases where the tumor was in, you know, lymph nodes, it was metastatic, so that you could say that maybe the LCA is staining the background hematopoietic cells. A lot of these were actually at the site of the origin of the tumor. And so one of their conclusions was, you know, that previous studies had demonstrated that LCA reactivity could be used to confirm lymphoid nature of, you know, dead cells, but that they would suggest a more cautious endorsement in those cases. And so this is really important for you to know when you're dealing with a necrotic tumor and you're doing a bunch of stains, and then to just assume if it's 45 positive that it's hematopoietic, which should definitely not be the case. And so back to this case, I will tell you what the resolution of it was. So, you know, we got it in heme path. We did a whole bunch of stains, you know, including CD20, nothing stained. And so we sent it back down to surge path and said, we don't think it's hematopoietic. And they finalized it basically just as a poorly differentiated tumor of unknown origin. And really, unfortunately, there was an autopsy, the patient passed away. And they did some cytogenetics on the liver tumor, and it was actually donor origin. It came from the donor. And just for those of you who don't know, a post-transplant lymphoproliferative disorder is almost always of recipient origin, so that wouldn't fit with the PTLD. And there was viable tumor elsewhere that they were able to take a look at, and it was actually a melanoma. So the necrotic melanoma portion that was sent for biopsy just wouldn't stain with anything. So this is just a cautionary tale that, you know, just because you see LCA staining, in especially in a necrotic tumor, does not necessarily mean it's hematopoietic. So. Okay. So yes, just to summarize. And then also, again, CD20 is usually pretty dependable. And just, you know, to note that sometimes you just can't tell in these really necrotic tumors what the cell origin is. All right. So I'm going to pivot now, and I'm going to show you a bone marrow, which, you know, I know many of you may not see bone marrow biopsies, and the only reason I'm showing you this is because I actually got this case, I got a case like this as a lymph node, again, in the past, and I don't have the slides for you, but this is the exact same presentation, but in a bone marrow, so I do want to show this case to you. So it's a 62-year-old woman, and she presented with cytopenias. And so they did a bone marrow biopsy, you know, thinking that she might have myelodysplastic syndrome given her age and her cytopenias. And the aspirate was aspecular, but I did have a touch imprint. This is what the touch imprint looked like. And of course, on this case, the clinician called me on the day the bone marrow biopsy was done. All I had was the touch imprint. She said she wanted a preliminary. So I looked at this, and you know what you can see. First of all, you don't have the normal tri-lineage hematopoiesis. You're not seeing, you know, different cell types here. It's all sort of one cell type. It's very monomorphic. So I said to her, you know, I know it's neoplastic, and then I kind of went through some of the things in the differential. And if you look at the cells, right, they're pretty discohesive, like single cells, and very plasmacytoid looking. So the nucleus is sort of pushed to the side. There's moderately abundant cytoplasm. So plasma cell neoplasm was definitely one thing in the differential. And so I did, you know, the plasma cell stain. We all think about CD138 on the core biopsy, and here's the CD138, and indeed it is positive. And you can also see it emphasizes the plasmacytoid nature of the cells. Here's one again with the eccentric nuclei. And then after you do 138, whenever you're working out plasma cell stains, you know, the next natural set of stains is a kappa and lambda, because you want to show light chain restriction. So I did do kappa and lambda, and you can see they're completely negative in the infiltrate. And you do know the stains worked because you can see some scatter positive cells in the background in both these stains. And so when you actually looked at the morphology on the core biopsy, it didn't really very much look like plasma cells. This is a higher power view. And if you look at the cells themselves, they've got pretty fine chromatin, these like delicate nuclei. They don't have that typical clock face chromatin you sort of expect in plasma cells. And if you zoom out a little bit on low power, the architecture was very telling. So, you know, they're forming these like very characteristic linear arrays. And I think most of you know when you look at this, the first thing you might think about is something like a lobular breast carcinoma that are sort of lining up in these single cell lines. And that is in fact what this was. We did a keratin stain, and you can see it's diffusely and strongly positive here. This was a metastatic lobular breast carcinoma. the woman had no prior diagnosis, so this was the first presentation, and she subsequently had a breast biopsy that showed it was lobular breast carcinoma, but she didn't have a known mass or anything. And I think, we all learned this in residency, that lobular breast carcinoma can mimic other things. It can look very plasmacytoid and often single cells. And I think, at least in residency, where I trained, we learned it as like a cautionary tale, especially in the context of like fine needle aspirations or FNAs. But I think knowing that in combination with the CD138 that it can stain carcinomas, there's a really high potential for misdiagnosis, because I think most people, including hematopathologists, think about 138 as the plasma cell stain, but it also stains epithelium and therefore carcinomas. So you can definitely misdiagnosis. And as I said, the initial case I saw that made me want to present this to you was an axillary lymph node in a woman that came from an outside pathologist. And it was much more subtle, I would say. You didn't look at it and think lobular carcinoma, looked like plasma cells, but it was a little bit off. The chromatin didn't look right. And the outside pathologist had done a 138, which was positive. And unfortunately, he was a community pathologist. He didn't have access to Kaplan lambda stains. So some of these smaller pathology practices don't have all these, this wide array of stains. So he didn't do a Kaplan lambda stain. He called it a plasmacytoma and sent it to us. And it was actually a lobular breast carcinoma. So always think about the possibility of carcinoma in your differential, even if something kind of looks like a plasma cell neoplasm. And although I've never seen this, apparently the converse scenario is possible as well. I did see this case report when I was sort of going through the literature. I thought it would show you where it was sort of the opposite scenario. It was a woman with a breast mass, and on the morphology sort of mimicked lobular carcinoma because it was forming these single cell linear arrays, but it was actually a first presentation of plasma cell myeloma. So. Okay, so now I'm gonna continue on the scene, but now we're gonna move away from non-hematopoietic tumors and talk about stains in heme path that you might associate with one lymphoma, but can also be staining other tumors as well, other lymphomas. So I'm going to focus mostly on cyclin D1, or some of your labs may still call it sort of one of the older names, BCL1. And so hopefully all of you think about mantle cell lymphoma when you think about cyclin D1. That's sort of the prototypic stain. To identify mantle cell lymphoma, you get this nice, strong nuclear staining uniformly in sort of all the cells, and that's of course because mantle cell lymphomas for the most part have a rearrangement in the cyclin D1 gene. It's rearranged with the IgH, their immunoglobulin gene heavy chain, so to get this 11-14 translocation. But what some of you may not know is that it does stain some normal cells. So this is a tonsil control for our cyclin stain that we have here, and you can see this is the epithelium of the tonsil, and it's certainly staining a subset of the epithelial cells here, so similar to CD138, which can stain epithelium. And then you can also see there's some spindly cells it's staining here. These are endothelial cells, and it also stains histiocytes. And so you're never going to have an issue mistaking something staining pattern like this for mantle cell lymphoma, but it is important to know about the normal staining when you're looking at some type of tissue for residual disease, if you're looking at a bone marrow for residual mantle cell or something else, to know that if you see a few positive cells, that doesn't mean that's necessarily residual disease. It could be the normal cells that are staining. And it does help to look at the morphology of the cells. You look at this and this is very spindly. It doesn't look like a lymphocyte, and the distribution that it's in vessels. So that's important. And then of course, I'm sure some of you, at least some of you know that cyclin D1 stains some other hematopoietic neoplasms. I'll go through some of the more common ones and then some of the ones that might cause issues for you. So, of course, cyclin D1 also stains a subset of plasma cell myelomas. About 20% of myelomas can stain with cyclin D1. So this is a bone marrow, and the plasma cells are staining with 138. This actually is plasma cells here, not a lobular carcinoma in this case. And you can see on the cyclin stain, it is staining, nuclear staining, and there's also some kind of weak cytoplasmic staining. And you can actually see that's a plasma cell from the morphology on the stain with the eccentric nuclei, as opposed to something like this, which looks more like an endothelial cell. And so the cyclin D1 rearrangement, unlike a mantle cell lymphoma, is not always present in cyclin D1 positive plasma cell myelomas, but it is present sometimes. And then, of course, the other sort of characteristic lymphoma that stains with cyclin you may or may not be aware of is this. So this is a case I had a few weeks ago. It's a 66-year-old man with pancytopenia and specifically monocytopenia and splenomegaly, very characteristic. These circulating cells in the peripheral blood, these atypical lymphoid cells with cytoplasmic projections. This is the aspirate smear, which was aspicular. This is the cord biopsy, and it shows this lymphoid infiltrate and the textbook phrase of fried egg appearance. Because there's so much cytoplasm in the cells, the nuclei are sort of pushed apart from each other. And here's the flow results. It's a 20 positive kappa restricted B cell population that expresses 25 and 11C. And so of course this is hairy cell leukemia. So cyclin D1 definitely stains hairy cell leukemia, but unlike mantle cell lymphoma, it does not have a cyclin D1 rearrangement. These typically have BRAF mutations, which you can sometimes at some institutions get a BRAF stain to show that, or you can do molecular. So, so something to be aware of. And the other, of course, I think most common use for cyclin D1 is differentiating mantle cell lymphoma from the other sort of main CD5 positive B cell lymphoma, CLL, SLL, right? And so I'm not going to go through this chart in detail. I just sort of put it here for reference, but we have this whole array of markers we use to help us differentiate between the two, either by flow or by IHC or both. And some of the characteristic features are CD20 and surface light chain, kappa lambda tend to be dim or negative in CLL, SLL, and pretty moderate in mantle cell lymphoma. 23 sort of also characteristic, usually positive in CLL and negative mantle. And of course, cyclin D1, what we're talking about here, this is an immunostain, and that's positive in mantle cell lymphoma for the most part, almost all mantle cell lymphomas, but not all, and CLL's negative for cyclin D1. And then SOX11, I just want to mention, this is a secondary stain, which you may or may not have available to you, but most reference labs will have this. So there are a subset of mantle cell lymphomas that are negative for cyclin D1, but those will stain with SOX11, and CLL, SLL should be negative for SOX11. So I think people use cyclin D1 all the time to confirm mantle cell lymphoma and rule out CLL, SLL. But one pitfall you should be aware of is that actually cyclin D1 can stain CLL, SLL. And so this is a paper from Pittsburgh several years back, and they showed cases of CLL, SLL, which are on the H&E here on the left, and you can see these paler areas on low power. These represent the proliferation centers, so the areas in the lymphoma where there are sort of a concentration of larger cells with nucleoli that represent pro-lymphocytes and para-immunoblasts, and these cells actually can stain with cyclin D1, so this is cyclin D1 stain on the right here, and so you're seeing a spattering of cyclin D1 positive cells specifically within the proliferation centers in these CLL cases, and they did immunofish, so they're able to look at the cyclin D1 immunopositive cells and do FISH for cyclin D1, which is a break apart probe they used. And so if it was positive, you would see the red and green signals would be separated, but they're together forming yellow signals. So there was no cyclin D rearrangement in these cyclin D1 immunostain positive cells. And so again, this is going to be, the staining is in CLL, SLL is going to look different than the staining in mantle cell, which should be diffuse and uniform. But if you're working up a case you think is CLL and you do a cyclin and you see staining, and that might cause some kind of confusion. So you should just know that you can definitely see cyclin staining in CLL, SLL. The other way I routinely use cyclin is in the differential diagnosis of large B-cell lymphoma. So one of the variants of mantle cell lymphoma you can encounter is pleomorphic mantle cell lymphoma. And if you've never seen a case, this is a case right here that I had actually as a fellow. And you can see that there's, sort of these sheets of really irregular, funky cells. A lot of them are very large. And you do CD20 stain and see their B cells, and you say, okay, it's a diffuse large B cell lymphoma. But actually, this was a pleomorphic mantle cell, and it had nice, strong, uniform staining for cyclin D1. So anytime I'm working up a large B cell lymphoma, I always do cyclin D1 stain to make sure I'm not missing a pleomorphic mantle cell lymphoma. But when you're doing that, you should know that as a pitfall, cyclin D1 can also be positive in diffuse large B cell lymphoma. And so it will stain a subset of cases. I routinely do cyclin on every DLBCL, and I would just say, a few times a year it's positive. So it's not super often, but it can definitely cause confusion. It's generally weaker staining and not in all the cells. If you do a SOX11 stain, that should be negative. And also, if you were to do FISH, they should not have a cyclin D1 rearrangement. And so there were 3 cases last week, at least that I know of, none of them were mine, but were of large B-cell lymphoma staining with cyclin. Oddly, they just sort of came up. And so this was one of my colleagues. And you can see there's sheets of large cells here. And this was the cyclin stain. So again, it's weak, and it's only sort of staining a subset of the large cells, but it could confuse you. You're trying to exclude a pleomorphic mantle cell, and then you see this cyclin staining. So this is pretty characteristic of the pattern of cyclin you tend to see in DLBCL, but anytime I do see this, I will do SOX stain, which was negative in this case, and recommend doing FISH, which is being done on this case as well, just to be 100% sure. But so just to summarize about cyclin D1, certainly not specific for mantle cell lymphoma, and it stains a subset of non-hematopoietic normal cells, which is important to remember when you're assessing for residual disease. And then besides mantle cell lymphoma, it stains a variety of other hematopoietic neoplasms. And when you're working these up and you might get confused in the differential diagnosis, you can always add on a SOX11 stain and or recommend doing cyclin D1 FISH if you're not 100% sure if you're dealing with mantle cell lymphoma or not. So. Okay, so just, I don't have pictures for these. I just wanted to sort of mention them because they're misdiagnosed cases I've seen. So CD117, or what you guys like to call c-KIT, I have seen a case of mastocytosis in the stomach, which was misdiagnosed as a GIST, because they're both positive for CD117. And of course, you can have epithelial GISTs, you know, and the cells look sort of more rounded like mast cells. And then mastocytosis, often the mast cells are spindled and abnormal, and so those can look like a GIST tumor. And of course, if you were to do an additional staining, like I don't know what stains you use these days to work up GIST, a dog one or something, or a tryptase on the mast cell end, then you would be able to tell the origin of the tumor. But you know, in this case, they didn't do that. They did a 117 and they assumed it was a GIST, and it was not. So definitely seen that. And then the other one, this is sort of a little pet peeve of mine, is CD30. So I see this a lot from people who are not the most comfortable working up heme path tumors, who get a lymph node and they're just sort of, they do it to make sure that they're not missing Hodgkin. So they just randomly throw CD30 stain on there. And the thing is, CD30 stains lots of things. So it obviously stains Hodgkin, right? So we all know that. But also stains some B-cell lymphomas, some T-cell lymphomas, activated T-cells. And then this is sort of the biggest problem. It stains immunoblasts. So immunoblasts are activated B cells in a lymph node normally, and they tend to be larger and have nucleoli. And so, you know, someone throws a CD30 stain on, and then they're looking, they see a CD30 positive cell, and they say, oh, that cell's kind of big and has a nucleoli, and then they misdiagnose it as Hodgkin. So I've seen this, I would say, at least 2 different times. So I never recommend doing a CD30 stain randomly to exclude Hodgkin, like throwing it on just in case, because it can really lead you down the wrong road. And it depends on how strong your stain is. Sometimes it can look really convincing, or if there's for some reason, an immunoblastic proliferation, you know, if there's like some kind of viral infection going on or something, it can really mislead you. So I recommend do not do it unless you look on the H&E first and you see cells that look like Rehm-Sternberg or Hodgkin cells. So that's my little takeaway for that. Okay, so just to summarize, be wary of LCA staining necrotic tumors, but on the flip side, CD20 can be helpful. Also, you should just be aware when you're using heme stains that it could be staining other things, normal cells, or even non-hematopoietic tumors, or even other lymphomas than the typical lymphomas you tend to associate with, you know, certain stain like cyclin. The control tissue can be helpful, especially if the tonsil control. Most of our heme stains here have tonsil controls, so then you can see other cells that might be staining. And then, you know, use resources. One of the nice things about being a pathologist, for most pathologists, I guess, unless you're at a very busy practice, is you have time to think about things and look things up before you have to put in a diagnosis. So I recommend PubMed, even if you don't have access to sort of the free full text. A lot of times you can tell from the abstract, you know, conclusion about stains and what tissues it might be staining. Path Outlines is a pretty good resource. You know, it's not 100% comprehensive, but it has this nice feature for, you know, if you click on the stain, it will tell you what stains normally and what disease things it stains, with links to papers it references. So that's great. And, you know, sometimes I Google, I'm going to be honest, you know, you have to be sort of critical about the source when you're Googling, but sometimes Google can help you. So, and then really the main takeaway, I think, is never rely on a single stain to make a diagnosis. And I know that that can be easier for me to say in heme path. I work in an academic setting. I can do lots of stains all the time. And if you're in a smaller community practice, you know, you have limited resources, you know, you have to pay for anything you send out. So, you know, you're maybe less willing to, you know, do a whole bunch of stains willy-nilly. But this is a first-time diagnosis on a patient. You know, you should really just take a step back before you make the diagnosis if you don't have, you know, another way of confirming it, you know, a separate stain, because you don't want to give the patient a wrong diagnosis. And, you know, the things I've sort of presented to you all came from real cases where there was a misdiagnosis. So. Okay, so now we're going to pivot to talk about flow cytometry. And I thought this was important, especially for people who are in the type of practice where they send their flow out to, say, a reference lab or, you know, a bigger lab, and then they get a report. And so they're just dealing with a flow report, and then they have the tissue. And this situation can definitely lead you down the wrong path. So I just want to show you some examples of that. So this was a case, a recent case, as a 60-year-old man who had a left groin mass, and he had a core biopsy of the groin mass at a satellite site. So where I work, there's a main campus, which is where heme path is located, and then there's about 27 satellite hospitals all over sort of Western Pennsylvania, and they all send their specimens for flow to us. So a lot of times we just get like a flow-only consult. And then depending on the pathologist or what the slides might show, they sometimes will send us the slides to, you know, make our own diagnosis, or sometimes they'll sign them out themselves. So this was a case where they just sent the specimen flow and they never sent the core biopsy slides. So I'm going to show you what the flow showed. So I've highlighted for you in green the population of interest here. It was a 10 positive, 20 positive population, and it had dim to, dim kappa here. And we actually, at our lab, also have BCL2 by flow. And so we did BCL2, and you can see it's positive. So it's a 10 positive BCL2 positive population. It is, something you would think about with follicular lymphoma. It's about 14% of total events. And also notice there's a background of polytypic B cells here. So it's not, all the B cells present are not this population. So, and this is how the flow is signed out. This is a very common way we phrase our flow reports here. And I think the reasoning for that will become pretty clear. So it was called the CD10 positive monotypic B cell population. And notice there's no word of lymphoma. We didn't say there's a CD10 positive lymphoma, and you'll see why. And so the outset, again, we've never saw the slides, but they signed it out as low-grade B cell lymphoma favor follicular lymphoma. And then the patient actually happened to come to main campus and saw an oncologist here, and they decided to excise the same lymph node that had had a core biopsy. So this was excised, and then I got that lymph node. So this is the lymph node, and it was small and on low power. There's nothing very ominous about it. There's some sclerosis, but this is a groin node, and that's pretty common to see sort of the sclerosis in groin nodes. There are patent sinuses. You can see there are some scattered follicles, pretty small follicles. Some have germinal centers, some don't. Here's a higher power. You can see there's histiocytes in the sinuses here. Here's a follicle with a germinal center. It's got an intact mantle zone. Here's some probably primary follicles. So looking at this, there's nothing that looks like follicular lymphoma, which is how the core biopsy was signed out. But we did have that flow finding, right, of a 10 positive BCL2 positive population. So of course we did stains, and here's the CD10. And hopefully what's apparent to you is that some of the follicles, so it is obviously highlighting the germinal centers, and some of them have much darker CD10 than some of the other germinal centers. So, here, sort of the ones on the periphery here are much brighter than, say, these germinal centers. Oops, sorry. And so when you do BCL2 stain, and you compare that to the 10, you'll notice that the really bright 10 positive germinal centers actually also have really strong BCL2 staining within the germinal center. And I'll show you a higher power. So here are two of the germinal centers that had bright 10. And then you can see here on the BCL2 that they have strong BCL2 positive cells in the germinal center, even stronger than the B cells around it. And then, this germinal center here, it's a little bit cut off, but it's more normal staining for CD10, and it's negative for BCL2. And then this follicle is really interesting. You can see in sort of the center portion of the germinal center, it's got really strong 10, and then at the periphery, it's really like a weaker 10, more like some of these other germinal centers. And when you look, the strong 10 corresponds to some BCL2 positive, strong positive cells in the center here, and then the periphery is BCL2 negative. So this is very characteristic for in situ follicular neoplasia, and there's no follicular lymphoma here, unlike what the core biopsy was signed out as. And so what is in situ follicular neoplasia, in case you're unaware? It's what used to be called follicular lymphoma in situ. In the most recent WHO, they changed the name. They want to take lymphoma out of the name and sort of differentiate it so it's not confused for lymphoma. And so typically the H&E can look pretty normal. You don't see anything on H&E. Sometimes the follicle can be a little bit monotonous appearing, like on the way to follicular lymphoma, but a lot of times it just looks normal, and some follicles, like the one I just showed you, can have partial involvement. And so the characteristic feature is what you see is based on immunostains. So you don't really see it on H&E most of the time. It's once you do the stains, then you pick it up. It's got really bright 10, brighter than the other normal germinal centers, and really bright BCL2, stronger than the surrounding T and B cells. And what's really important to know, and why it's a pitfall, is that the flow will show a monotypic B cell population half the time. So especially if you're getting a flow report from the outside lab and they're saying there's a CD10 positive B cell lymphoma, I see this all the time phrased this way, and then they'll give you a differential, right? They'll say it could be follicular lymphoma or diffuse large B cell lymphoma or Burkitt or something, and so you're seeing this report that says lymphoma and you're looking at the lymph node, you're not seeing much. This could be why. And so overdiagnosis in this case could have been really problematic, right? If this patient didn't get an excision, they're walking around with the diagnosis of lymphoma. They might have gotten unnecessary chemo. Now, low-grade follicular lymphomas, they often won't get chemo, maybe on observation. Sometimes they'll get rituximab, but you just never know, and you don't want to label this patient with lymphoma if they don't actually have lymphoma. Now, on the other hand, hopefully this doesn't scare you, because you're not going to pick it up unless you do stains, and we all know that you look at a ton of lymph nodes and you're not staining 90% of them because you're screening them for metastatic carcinoma or what have you. So if you're missing it, the harm of it is probably negligible. The clinical significance of this is sort of controversial. There's basically three described clinical paths that can happen. So one thing is that nothing happens. The patient doesn't go on to develop follicular lymphoma. That's just an incidental finding. The other is that they could progressed to follicular lymphoma in the lymph node in which you saw the in situ follicular neoplasia. And then the third is that there actually could be concurrent follicular lymphoma in the patient at another site. And so the reason we stain for this and report it, even though sort of is, you know, may not be that clinically significant, is that really what the clinician should do is just do some kind of staging of the patient, look for adenopathy elsewhere. And if they have like a big lymph node somewhere, then they should take that out because it could represent a concurrent follicular lymphoma. So. All right, so this is a different way that you can be misled to misdiagnosis by flow. And I'm going to show you this case via text message, actually. So my former co-fellow, she actually works as a general pathologist. She does get to do about 50% hemopath, and then the rest is, you know, completely general. She does neurofrozens and cytology and all of that. But she doesn't have any other hematopathologists that work with her. So she sends me consult cases all the time via text message. So this was a few years ago. She sent this picture. And then this was her text, which was poop emoji. So you can imagine the expletive she was thinking in her head. And she said, you know, I just had a marrow that I had already written up as CLL. It was 95% involved in the marrow, and the white count was very high, 200,000. And the flow had a DIM20, DIM-kappa, 23 positive phenotype. And if you think back to the chart I showed you, that's like very typical characteristic phenotype for CLL, SLL, which is why she had written it up as that way. And then she said, cyclin is the only stain I ordered on the marrow, and I just got it back. And so you can see this had strong diffuse cyclin staining. So this was actually mantle cell lymphoma, and she had been fooled into thinking it was CLL based on the flow. So mantle cell lymphoma can definitely have a CLL phenotype by flow, and conversely, CLL can look just like mantle cell by flow. And characteristically, CLL with trisomy 12 abnormality tends to have a phenotype that is more like mantle cell with decreased CD23 and higher CD20 and surface light chain staining. So I never make a diagnosis of CLL unless the cyclin D1 immunostain or FISH is done. So, you know, a lot of times we'll see a peripheral smear and then we'll get the peripheral blood flow and, you know, to look like CLL. I never sign out those cases of CLL for this exact reason. So what I say is that, you know, it's a CD5 positive B-cell lymphoproliferative disorder and that has a CLL-like phenotype, but I couldn't exclude mantle cell unless they were to do the cyclin D1 FISH, or if they did a bone marrow and there was cyclin D1 staining. And so, you know, I feel like it's our duty to educate clinicians because, you know, they just see a high lymphocyte count in an older patient, and if you say the phenotype's like CLL and they say, okay, it's CLL, and then they just go on and observe them. And if it was really mantle cell, that can be really detrimental because it's a very different prognosis. You know, CLL tends to be more indolent, mantle cell is much more aggressive, and they have different treatments. So it's really important not to make a misdiagnosis. And so this is how I responded to her. Which is true. I never make a diagnosis of CLL based on the whole, even if everything is perfect. And you know, let's say 95% of the time you do say it's CLL, you're going to be right. But those 5% of the time that you miss that, you know, you could relegate the patient. They could progress without treatment. You know, there could be a lot of issues with it. So I try to just kind of keep this in mind. So just to summarize, the pitfalls with flow cytometry, flow can definitely be misleading. It could look like lymphoma by flow, but not actually be lymphoma. And as I said, especially if you're sending your flow to a reference laboratory and getting an outside report that's saying there's a 10 positive lymphoma, you know, that might not be accurate. So you have to just be really careful for in situ follicular neoplasia. You can also get phenotype misdirection. So as I showed you with the mantle cell CLL and vice versa. And also, of course, our lymphomas don't read textbooks, as we like to say, right? So you can definitely have a CD10 negative follicular lymphoma, a CD5 negative mantle cell lymphoma, or CD5 positive marginal zone lymphoma. All of these are possible. So, you know, you just kind of have to keep that in mind. Another pitfall, which I didn't talk about, but and hopefully some of you know this, that flow can definitely be negative, but you can still have lymphoma present. So characteristically Hodgkin, right? So a lot of times you're not going to see anything on Hodgkin. The cells are sort of few and far between. You have most of the cells are sort of background inflammatory cells. And also the Hodgkin cells are quite large. They don't flow well. And so unless you're collecting, you know, like 1 million or 2 million events and you're at, you know, University of Washington, Seattle, you're not going to see anything on the flow for Hodgkin, except with the exception that you often will see increased CD4 to CD8 T cell ratio. Of course, this finding is completely nonspecific, and you can see that in all kinds of things, including, you know, reactive things and sarcoid and what have you. But if you do see a case that looks like Hodgkin to you and you see the flow report and it does say that, that is a little clue to help you, that you might be on the right track. T cell lymphoma is very classically, they don't all have antigen loss. So if you don't have loss of like 2 or 7, or they're not all 4 positive, then you can definitely not see anything on the flow and still have a T cell lymphoma. And then diffuse large B cell lymphomas for sure often don't flow well, particularly if necrotic. They just don't go through the machine. And I think this is less of an issue for misdiagnosis, right? Because if you have a lymph node and you look at it in sheets of large cells, you're not going to say, oh, the flow's negative, this is not lymphoma. But just be aware that just because of the result comes back from flow saying one thing doesn't mean that, you know, it's accurate. And so really the critical takeaway is that flow is an important and really helpful tool, but it is not diagnostic in isolation. So you always have to correlate it with the morphology and the stains that you're doing on the tissue. Okay, so now we're going to pivot to hidden lymphomas, and I will say the caveat is that they're not all hidden and they're not all lymphomas that I'm presenting, but sort of the recurring theme is things that you are going to see in your routine surgical pathology practice where you're not thinking about lymphomas, but they might be there. So, okay, so the first one was a 61-year-old man. He had a screening colonoscopy, and they saw some polyps. One was a tubular adenoma, which I probably can't even diagnose at this point, unfortunately, and one showed this. So you can see this is the colonic epithelium. And then there's all this sort of mucosal fat, and I don't know if some of it is lymphatic, but sort of pushed up here. And this is probably what caused the appearance of the polyp on the colonoscopy, for them to excise it. And so, this came from an outside pathologist. They looked at this, and what they noticed was this area. So this was not hidden to them. They did see it, and that's why they sent it to us. And so this sort of grabbed their attention. So let's look on that higher power. You can see there's some kind of infiltrate. It's a little bit hard to see on this power, but you can see it's discohesive. And it's, in this little mass area at the base of the polyp, it's also sort of extending out in between the glands here into the epithelium. And on higher power, hopefully you can see their plasma cells, or they look like plasma cells. This is becoming the hidden recurrent theme of my talk, actually, right? Plasma cells. So they look very plasmacytoid, and it's a little bit hard to see the chromatin, but they do have nice clock-based chromatin. So he thought, is this a plasmacytoma? And so, of course, we did a CD138, and that definitely stained. And notice, as just a callback to my earlier point, it is also staining the glands here, right? So CD138 also stains epithelium, but you're seeing the plasma cells staining, or what we think are plasma cells. And then, of course, the next thing we're going to do is kappa and lambda stains. But unfortunately, in this case, the kappa and lambda stains were really difficult to interpret. There's just a lot of background, and we couldn't be sure that it was restricted with one way or the other. So, what do you do in this case? You obviously don't have flow. This was just a polyp on a screening colonoscopy. And so it's good to know what other stains you can use to help you identify abnormal plasma cells. So obviously the gold standard would be kappa or lambda restriction, but one, they're not always available. As I mentioned in that first case where the outside pathologist had, thought it was a plasmacytoma, even though he didn't do kappa lambdas, because he didn't have those stains available to him. Also, a lot of places will do kappa lambda by in situ hybridization, right? And so if you don't have preserved RNA, then your itch stains are not going to be informative, so that can be a problem. And then also, this is a really important point, if you have background normal plasma cells present, especially a lot of them, it can be really difficult to detect restriction. So let's say you're, in a bone marrow, if you have 5% plasma cells and 2% of them are a kappa clone and then 3% are polytypic, you're never going to see kappa restriction on the immunostains. So it's really helpful to know that there are other stains you can use to help you identify abnormal plasma cells. So other ones you can do, we've already talked about one, of course, cyclin D1 is positive in about 20% of myeloma. So if you see cyclin D1 positivity, then you know it's abnormal. Other things, CD56, probably most of you know that. CD20, so that's not normally positive in plasma cells, but it is positive in a subset of myelomas. And then one you may not know is CD117 or c-KIT, again, back to the mastocytosis gist. So it also can be positive in plasma cell myeloma. And then negative stains are also helpful. Many of you may not have this available, but we do have CD19 by immunostain, and so that can help too if you don't have flow. Plasma cells are typically CD19 positive, but are often CD19 negative in myeloma. So in this case, on this colon polyp, I did do these stains, and I got lucky. One of them was positive, and that was the CD117. So here's the CD117 stain. You can see it staining in the base here and also in between the glands. And if you compare that to the adenomatous polyp, this is the CD138 on the left, again, staining epithelium, but it's staining plasma cells that are present, which are presumably normal plasma cells, and this is the 117 in that area, and that's all negative. So you can see that the plasma cells in that one area of the polyp were definitely neoplastic, and so this was signed out as a plasma cell neoplasm, incidentally found in a colon polyp. And so just some pearls and pitfalls about plasmacytomas. You all know they can be found anywhere. They're most common in the extramedullary, most common extramedullary location is the head and the neck. So when you're doing those neck dissections and things, just sort of be on the lookout. They can be subtle or difficult to distinguish from reactive plasmacytosis, especially in sort of, places where you normally see plasma cells, and you may wonder if it's chronic inflammation. And obviously there's absolutely no need to stain every biopsy where you see a lot of plasma cells present. You know, you'd be staining a ton of, you know, gastric biopsies if you're doing that. But if there's something forming a mass, like in this case, there's sort of forming a mass at the base of the polyp there, then you should sort of pay more attention and think about, is something going on there? And as I mentioned, kappa and lambda can be hard to interpret or may not be available. So it's good to know what additional stains you can do in those cases. Okay, now I'm going to move on to a different kind of case. And the next two cases are really about when you're looking at all these lymph nodes that you're screening for metastatic carcinoma in your staging procedures. And so that's exactly what happened here. This is a 65-year-old man. He had prostate cancer, and so we got a prostatectomy and a bilateral pelvic lymph node excision, as they tend to do. And those were signed out to lymph nodes as no metastatic carcinoma. And then this is literally how this happened. A year later, the patient developed a lymphoma, and the oncologist had noted that the patient had pelvic lymphadenopathy at the time of the prostatectomy, but then no metastatic carcinoma was reported. So he actually called us in HemePath and asked us to review the lymph node size from the time of the prostatectomy. This is a real case. And said, you know, is there actually lymphoma there? Is that the reason why he had enlarged pelvic lymph nodes, you know, because there was no carcinoma? And so we looked at the lymph nodes, and they were quite large. Here's 1/2. I can only fit, actually it's probably like 1/3. I can only fit 1/3 of the lymph node in the 2x view. But this looks pretty normal. You can see there's patent sinuses here, subcapsular sinus. You've definitely got, you know, some histiocytosis. There's some sclerosis, but again, it's a pelvic node. And then the architecture is maintained. There are mostly what look like primary follicles sort of scattered around. So this looked all fine, but then the other side of this lymph node looked like this. So even if you have no idea how to diagnose a lymphoma, like if you were looking at this lymph node, this side looks very different from this side. So you should say like, wait, something's going on here. Maybe I should take a closer look. And what you see is that there are these follicles that are, you know, really crowded follicles sort of all back to back here. And on higher power, the follicles sort of lack the normal features you would expect in a normal germinal center. So you should see polarization with a light and a dark zone. That's missing here. You don't see tingible body macrophages, which you typically see. It looks very monotonous. And then the mantle zone is completely basically missing. You usually see a darker rim of blue cells that represent the mantle zone outside the germinal center. That's missing. And on higher power, these cells, you know, they're mostly smaller lymphocytes. They've got, you know, cleaved nuclei, and so these are centrocytes, and so this is completely characteristic for a low-grade follicular lymphoma. And so this, the stains we did here, you can see CD10, it's highlighting all those follicles, and BCL2, which should normally be negative in the germinal centers, is positive in all of these, and that's diagnostic of follicular lymphoma. And so this had to be amended to say partial involvement by follicular lymphoma, grade 1-2 of 3. And so I just want to say be vigilant when you're screening the lymph nodes for metastatic carcinoma. This is the, again, you know, when you're looking on low power, this doesn't belong, right? So something just seems off. So if something looks different than the other side, you know, go take a closer look, maybe go on higher power. And so that's just the moral of that story. This is another lymph node, same kind of situation. 47-year-old man with squamous cell carcinoma, and he had one of those like hemifacectomies they do. And so as one of the lymph nodes in the neck dissection, the surgical pathologist saw something and he sent it to us. So this wasn't really hidden. He picked this up, but I just thought it was a neat, interesting thing. I want to sort of contrast it and show you. So this is the lymph node, and again, low power features, nothing really stands out. Retained architecture, nice intact thin capsule, patent sinuses. But then one other area of the same lymph node on the other side look like this, and that's what caught the pathologist's eye. So there were these really pale areas towards the medulla, which are sort of looks like they're in sinuses. And if you look at that on higher power, you can see that there are these eosinophils sort of admixed with some pink cells. So lots of eos in here. And then at higher power, here's the quote pink cells. So they're kind of irregular, and they have these nuclear grooves, which hopefully you can see while there. They look, you know, coffee bean shaped. And indeed, the areas are positive for S100 and Langerhans. And so this was a focal involvement by Langerhans cell histiocytosis. And what stood out to the pathologist, who again was just screening these lymph nodes for metastatic squamous cell carcinoma, was those like pale areas. And typically Langerhans cell histiocytosis, when it starts out, is primarily in the sinuses, and then will expand out to the paracortex. So it sort of fit, everything sort of fit. It was a really nice characteristic case. So just the takeaway of lymph node screening, you look at so many more lymph nodes than a hematopathologist. Like, I'm sure there are many days you look at more than 100 in a day, and you know, I never see that many. And almost all these that you're looking at don't have flow cytometry, right? Because you're not looking at them for lymphoma, you're looking for metastatic carcinoma. So no one can expect you realistically that you can critically read them off for lymphoma or some other hematopoietic disorder. And so something subtle or some kind of subtle lymphoma, I don't think that anyone's going to expect that you're going to be picking that up You know, that's not what the purpose of you screening these lymph nodes is for, but you should be able to detect noticeable changes on low power, right? So if one side of the lymph node looks very different from the other, you should pick that up. Or areas that stand out, like in that Langerhans cell case, there are those pale areas that really stood out. And so if you see something like that, then you take a minute and stop, look at it on higher power, and see if you maybe need to show it to someone else or do some stains to work it up. So that's sort of the takeaway of my pearls for lymph node screening, which you do on a daily basis. And I can't imagine how hard it is to, you know, be aware of all these other things while you're looking for metastatic carcinoma, but you do need to do that, right? So those are my pearls for that. And then finally, I want to show you a trauma spleen, which I don't know how many of you look at these. I feel like a trauma spleen is like a hot potato. No one wants them. Like in some places they go to GI, some places they go to soft tissue, some they go to hemopath, and everyone's always trying to bounce them around. Where I work currently, we routinely receive them in hemopath and work them up, and I still hate them, even though I see them, you know, kind of often. So this was a trauma spleen case. A 64-year-old man presented with splenic rupture and hemoperitoneum. I think he fell off a ladder or something. And he had a splenectomy, and his spleen was 830 grams, which is really, really large. So 200 grams is sort of the upper limit of normal. And so I just want to show you this is what it looked like. And the white pulp nodules were, you know, sort of intact. There was nothing really impressive about that. The red pulp, however, was super expanded. And you can see that a lot in trauma spleens, especially because of red cell congestion. A lot of times there's just a lot of congestion. And then looking at the actual cells themselves, there wasn't really much like that stood out. You know, we couldn't really tell what was going on, what cells were in here. Was there extramedullary hematopoiesis? I don't know. So we did the stains, the first stains that we always do in hemopath usually are 20 and a 3 when we're thinking about, you know, is there lymphoma present? I'll come back to the stains. We did have flow, but it was basically useless. It was very low viability. It just showed a few T cells, which were mostly CD4 positive. This is the 20 and the 3. The 20 showed intact B cell nodule in the white pulp. And then CD3, definitely you see T cells in the red pulp, but this was a lot. This is way more T cells than you typically see in the red pulp. And when you looked at higher power in the CD3, you could see that there are these massively large atypical cells. So here's sort of a normal size lymphocyte, and then there's this like hunkin' big guy here. So this was really unusual. So very large CD3 positive cells in here. So we did, of course, we did a bunch more stains. I'm not going to show them all to you, but I will show you sort of the 2 most interesting and relevant. Here's the CD30. You can see that staining all throughout here, and you can really see it highlighting these larger cells here. And here's ALK, and so ALK was positive as well. So this was an ALK positive anaplastic large cell lymphoma, totally incidentally found in this trauma spleen, and I actually thought it was really subtle in H&E. And when I went back and searched really hard after doing all the stains, I could find, you know, some cells that maybe look like those hallmark cells you see, but really it was not very easy to tell. So my pearls about trauma spleens, you obviously are not going to work with every trauma spleen. And we actually, even though we're hemopath, we usually don't even do stains on spleens that are normal weight unless something doesn't look right. But the weight is so, so important. And that's the first thing I always ask the residents when I'm signing out and we're looking at trauma spleen, how much to weigh, how much did it weigh? And so we only flow spleens at UPMC if they're greater than 200 grams or if there's some kind of clinical suspicion for hematopoietic disorder. And of course, you can have a spleen that's larger than 200 grams and there not be a lymphoma there. There's lots of benign disorders. But if it's larger than 500 grams, that really should be a red flag. That's very, very large. Like in this case, it was 800 and something grams. And so that really should be a tip-off that you should, you know, take a closer look and work it up or send it to hemopath. Try and send it away to someone else to work with the spleen if you don't want it. But so that's my pearl on trauma spleens. And now I'm going to pivot lastly to peripheral smears, specifically how to spot a blast and when you may be fooled. And so my very first pearl is the stain quality is so, so important. So in my prior institution, we used to get a lot of peripheral smears from a bunch of small outpatient labs where there literally wasn't, it was just like an outpatient clinic, like a heme-onc clinic, and then a tiny lab in the clinic. And so there was no pathologist there. So they'd send them to us to review when they saw something that looked like, you know, an other or whatever on a peripheral smear. And this is like literally a picture from one of the slides that I would get there, and they'd send this to me and be like, is this a blast? And I'm like, I have no idea what that is. This is terrible stain, you know. And then you get a better stain and you're like, oh, well, that's clear lymphocyte, it's not a blast. You know, not only with blast, but that can fool you with something like dysplasia. You know, this is another example of one of those stains from some of those outpatient labs. And, you know, you look at the neutrophil, you can tell it's a neutrophil, right, because of the nucleus, but then the cytoplasm looks so pale, it looks hypogranular, and you're thinking, oh, does this patient have myelodysplastic syndrome? They've got these hypogranular neutrophils. And then you get a better stain and you're like, oh, it's a completely normal neutrophil. So the stain quality is so important. Basically, it's usually not a problem unless you have a small volume lab and they're doing the stains manually, because then basically what happens is the stain gets old and they don't change it, and then it just doesn't work as well. So if you're in one of those places, I would just say make sure your lab changes the stain often. And if you're getting a slide you don't feel comfortable, the stain doesn't look great, ask them to make a fresh batch of stain and repeat it. Sometimes it's an issue on the automated analyzers as well. I mean, they have obviously you know, a time system where they're replacing the reagents, but sometimes they just get older. So especially if you don't have a high volume, so ask them to change the reagents. You know, I don't care how well you're trained, if you don't have a good stain, you're not going to pick up the blast. It's, you know, there's just no way. So that's my very first thing about stain quality. And then I'll just quickly talk about blast mimics. So I think if you look at a lot of peripheral smears, you're not going to really confuse reactive lymphocytes for blasts, but if you're not used to looking at them that often, you possibly can. They're typically seen with viral infection. Usually the prototypic is like EBV infection. And these tend to be larger lymphocytes, but they still have a pretty low NC ratio because they basically have abundant cytoplasm. And some of the characteristic features are what one of my mentors used to call Dutch skirting, where the edge of the cytoplasm is sort of a darker blue or a deeper blue than the rest of the cytoplasm. The cytoplasm will tend to mold around the red blood cells like that. But the chromatin will still be mostly condensed. And one of the things you'll see is like the lymphocytes in general, the population of lymphocytes on the smear will look polymorphous. You'll see sort of a spectrum of morphologies, whereas, you know, blasts, they tend to be a bit more monomorphic. And so additional tips for these, just patient age. So like I said, EBV is sort of the very prototypic thing. You know, I used to see in my old job, like, I don't know, at least 5 to 10 of these a week of EBV. And so if it's like a teenager, the very first thing I do is check for monospot test results or EBV serology. And the other thing that can be helpful is if there's cytopenia. So like a young person with a viral infection, they shouldn't have like anemia or thrombocytopenia really. So if you see cytopenias, there might be a clue that these might not be reactive lymphocytes, something else could be going on. The other thing that can mimic blasts are mature lymphomas. And so obviously you want to pick up lymphomas too, they're abnormal cells, right? But you don't want to confuse something like a CLL for an acute leukemia because that has really different, you know, patient implications. And so, you know, just be aware that mature B and T cell lymphomas can mimic blasts. And so you don't want to rely on something like nucleoli. These are some examples. These are circulating marginal zone and mantle cell lymphoma cases I've had in the past. And you can see they all have these really nice nucleoli, but these aren't blasts, these are mature B cell lymphomas. And this is a TPLL, and of course by definition, it's a T cell prolymphocyte, so it tends to have a nucleolus. So, you know, that is not a feature I would use to pick a blast. Really, and this comes straight from one of my old mentors, said chromatin is the key, and I've sort of always kept that in mind. And so in this picture, hopefully you can tell 2 are blasts and 1's a lymphocyte. And this is a lymphocyte, and the way I can tell that is the chromatin. So chromatin in blasts, for the most part, tend to be like nicely uniform and fine and smooth, where in lymphocytes they're a lot more condensed. You've got these sort of darker areas and these lighter areas. And so the chromatin really is the key to picking up blasts. So on that note, I'm going to show you a quick case, and we're almost done. So this was a 62-year-old man, and he had leukocytosis, anemia, and thrombocytopenia, and there are 40% others identified by the hematology lab. I actually had this case when I was a fellow on call on a Sunday, and I came in to look at the smear, and this is what it looked like. And I said, oh, these cells are really large. You know, here's a neutrophil. And of course, a normal lymphocyte is the nucleus about the size of a red blood cell. So these are really large. They've got nucleoli, you can see those, right? And then what do you see in the cytoplasm here? Our rods. And so we all learn, right? I think some people even learn in med school, our rod equals AML. If you see an our rod, that's like the one way you can tell that something's a myeloblast versus lymphoblast. So I saw all these our rods. But at the same time, I was looking at the nuclei, and I said, the chromatin doesn't really look right. You know, it looks very condensed in a lot of areas. And I even said to the oncologist on the phone, I said, you know, the cells look, the nuclei look almost lymphoid, but then there's our rods. So I guess it's an AML, and that's literally what I said. You know, I just sort of pushed the chromatin issue to the side because I said, oh, our rods, our rods. And then we had the, you know, the flow cytometry the next day on a Monday. And this was the flow here. The cells were in pink. They're 45 dim, which is what you would see in blast. They're not expressing CD34, CD117. There was no 13, no 33, and there's a little bit of DR. So they basically weren't staining like myeloblasts like you would expect. They didn't have MPO. And so then we did a few other things, and back to the hidden theme of my talk of plasma cells, this turned out to be plasma cells, the great mimicker. So they're positive for CD138 and kappa restricted, and so this was a plasma cell leukemia. And you can see our rod-like structures in myeloma. They're composed of different enzymes than the our rods in myeloblasts, but they do pop up, you know, every now and then. And really, the chromatin was the key, and I slowly ignored that. You know, I said, you know, they look really, the chromatin doesn't look right, but so this was it was led astray, and I should have paid attention to the chromatin. Now, when you may be fooled, so going with the chromatin theme, I'm going to show you this case. 20-month-old female, she came in with bruises, viral symptoms, and fevers. And you know, with kids, with infants especially, those are the kind of features you see in both hematopoietic disorders and just acute illnesses, and there's no way to sort of work it out. The CBC showed mild pancytopenia, and there were 16% others identified by the hematology lab. And this is what the cells look like. So again, large comparing to the red blood cell here. They've got irregular nuclear contours. You can see little nucleoli. But the chromatin looks quite condensed, you know, definitely dark areas and light areas. I would say that does not look very much like a fine chromatin you typically see in blasts. But actually, these were blasts. This was a BALL. You can see the flow here. 34 in TDT positive, 10 and 19. These are sheets of blast in the marrow. And so this was a BALL. And chromatin, I would say, in lymphoblasts can definitely fool you. And it's often more condensed than you would typically expect and can resemble more mature lymphocytes. I myself have almost missed a TALL that looked very, very mature in the peripheral smear. And thank God the patient had a mediastinal mass, so they didn't sort of brush it off. That same week, literally that same week of this ALL case, we had an 8-week-old boy presented with fever and cough. CBC showed mild leukopenia, and there were 3% others. And this is what the cells look like. So here we go again. High MC ratio, irregular nuclear contours, large cell. And, you know, is this ALL too? Well, no. The patient ended up having a diagnosis eventually, which, you know, we don't know for like a week, of acute bronchiolitis. And there was no ALL. They didn't do a bone marrow. And these were actually kitty lymphs. So for those of you who don't know what kitty lymphs are, they're circulating hematogones, normal B lymphoblast precursors that usually live in the marrow. And you typically see them in kids age 2 or younger. They have irregular nuclear contours, fine chromatin, scant cytoplasm. And there's no way to distinguish them from abnormal lymphoblasts because they literally are blasts. So morphologically, you look at them, they look like blasts because they're blasts. So the only way you would be able to distinguish this from ALL is by doing flow. And by flow, they'll have this sort of more heterogeneous phenotype where blasts in ALL will tend to be sort of a more homogeneous phenotype. And so when you compare the two cases, again, 2 of these pictures are from the kitty lymphs and 2 are from the BALL. And I can't tell you which is which. But some of the features that can help, not always, but you know, the age. Now, this patient was still less than 2 years old, so you still could be thinking kitty lymphs, but they're sort of on the older end where this kid that was the kitty lymphs was 8 weeks old. The BALL patient had pancytopenia. This patient only had mild leukopenia, and the percent of abnormal cells. So the patient with BALL had 16%, the kitty lymphs are about 3%. Now, you certainly can have ALL with just, you know, 1 or 2 circulating lymphoblasts. But, you know, the sort of combination of not like pancytopenia, few of abnormal cells, and pretty young should sort of push you towards kitty lymphs. And so with that, just my overall pearls for identifying blast stain quality is super, super important. Chromatin is the best indicator of all the different things, the features of cells, but it's not foolproof, especially when it comes to lymphoblasts. Things you can typically exclude are viral lymphs and kitty lymphs sometimes, and things that can help you are the percent abnormal cells, the presence or absence of cytopenias, and patient age, you know, teen, thinking about mono, or less than 2, thinking about kitty lymphs. And I always say this, and I do this, if you're in doubt, and you can always categorize, keep them as others. If you don't know what they are, you don't know what they are, with a descriptive comment and a recommend flow. Now, within reason, you don't want to do this on every case. And then the other thing that can be super helpful is calling the clinician. You know, like, you know, we tend to be in our little silos, but they like to hear from us, and you can learn a lot on both ends. So, you know, talking to the clinician saying, hey, this is what I'm seeing. Are you worried about it clinically? And that can really make a difference. I have had cases where I call them and they say, oh, no, I'm not worried. And so I say, okay, fine. So we don't do flow. And I've had cases where I call them and I say, I'm not worried. Are you worried? And they say, yes, I'm worried. And so we flow it, and there's something there. So that can really make a big difference. So I always say in the end that communication with the clinician is really important, and flow is a good tool to help you in these cases. And so just to summarize what I went over today, heme, you know, what we think about as heme stains, they can be positive in normal cells and non-hematopoietic tumors, and they're not even always specific for the lymphomas. You may typically associate them with like cyclin D1 or mantle cell. Flow results can certainly be misleading, so you need to always use them together with the morphology of the tissue and never in isolation to make a diagnosis. Lymphomas can, as we all know, occur anywhere, but also may be subtle. So you should definitely keep your eyes open when screening lymph nodes for carcinoma for obvious changes. No one's expecting you to pick up subtle things. And pay attention to trauma spleens if they're enlarged. And then blasts, we all know, can be difficult to identify. Chromatin is generally the most reliable feature. Look out for kitty lymphs in the right clinical context, and flow and communication with the clinician can help. And with that, I'll take questions. Jason, are there any questions?
Yes, so thank you so much. There are two questions, and one was from Dr. Wang. When you showed the first case, the question was, is the LCA positivity due to non-specific staining of necrotic or dying tissue?
Yeah, I think that's what it is. I don't know if anyone knows specifically, but it's definitely, not, attributed to just background like lymphocytes that are present. I know people have said, oh, they're tumor infiltrating lymphocytes is staining that. No, it actually will stain the necrotic cells themselves. And I don't know the exact pathophysiology, but it is, it's not from background, not hematopoietic cells. It is the tumor cells themselves. So, yeah.
Oh, fantastic. Now, there was another question from Dr. Duker. His question was, at autopsy, necrotic or autolyzed previously undiagnosed tumors are encountered at autopsy. Are there most useful immunostains for screening these tumors?
Oh, well, I couldn't tell you about outside the heme path realm because I would have no idea. But like, if you're thinking about, one of the more common things of B-cell lymphoma, CD20 is just, I would say, the best one. A lot of stains are not reliable once on the heme realm specifically. Once things are necrotic, something like CD10 is awful. That stains neutrophils, can stain a lot of necrosis. A lot of stains won't work anymore in necrotic tissue, or if something's been decaled, like BCL6 is unreliable. So I would say 20 is really the only one I can say reliably will stain necrotic lymphoma B cells, of course. So that would be the only one, honestly, I can tell you outright.
All right. I don't think there are any additional questions. So with that, thank you so much. This was a wonderful presentation. And if anybody has any question, you can reach out directly to Dr. Moore as well. And
Yeah,
we'll
absolutely.
be happy to answer the questions. With that, thank you all for the program today.
Thank you for having me.
Everybody will be able to get their CME credits, so please look out for those and ask for those. And those who are in Pennsylvania, I urge you to become the members of PAP Society as well. But thanks for everyone for joining out. Thanks. All right.